By the way, I've been looking forward to this for months. I feel like this is a rock star panel on the area that's the hottest topic for me whenever I talk to provider leaders. They're talking to me about what they're doing with ambient speech. And I thought this is something I would watch on pay-per-view TV if this was on HBO. So excited for the group of leaders that are here today. By the way, I told my team, I said, we're doing this panel at the wrong summit. I said, this should be at a clinical excellence summit. This should be at a clinical usability summit. And they said, Adam, once you learn what's going on, you will change your mind. So just know I've started to change my mind. I think it belongs at both, which is so unique, where you have a tool that can both change things clinically and change things on the revenue cycle side. And I shared this in a podcast that I did about a week ago, but I've been in this business for 28 years. I don't think there's been a space where I've seen sort of the giddiness of leadership of the things they've been able to do in such a short period of time. And I know that that's not easy to keep that sort of giddiness. Once you perform one miracle, they expect the next one, pretty quickly after that. But with that said, here we are at the Revenue Cycle Summit. We're going to focus more on the revenue cycle side than the clinical side. But when we talk about differentiators and things that get you pumped, I'm happy if you share anything that ties clinically, because they really are both very important on this side. So I am going to make sure we keep this short and sweet, and because we have broken the key rule of panels, which is never have 6 people on a panel. Never, ever, ever do that. So we're going to try to keep this short and sweet. I would ask just our leaders up here to keep your responses to about 2 minutes. If at some point you're going too long, your ejection seat will go.
We can do some M&A here, just consolidate.
Okay,
that would...
Perfect. We'll see who's still here next year and who the leaders are. So if we can just keep our answers short and sweet, and I will do just quick intros, starting on the far end with Shivdev Rao, who's the CEO and co-founder at Abridge. I could say a lot more things about that, but we'll keep it short and sweet. So Nikhil Buduma, I told him I didn't know how to say his last name because it's like one of those rock star names. Just have you talked to Nikhil? So he's like Madonna, I guess. Chief scientist and co-founder at Ambience Healthcare. Ian Shakil, founder and CEO of Augmedix, now part of Commure. Thank you for being here. Matthew Coe, the CEO of DeepScribe AI. Punit Soni, the CEO of Suki. And then Rizwan Pasha, the Chief Medical Officer, Health and Life Sciences at Microsoft, AKA Nuance. I'm not sure which one you want us to call, but Microsoft. Perfect. So welcome, thank you for being here. We're going to jump right into the questions. And by the way, we're going to try to save 15 minutes at the end for you to ask whatever amazing questions you want. So be prepared for what you'd like to throw out to this great group. I want to start with this. Again, there's sort of a clinical focus as acquisitions are made, as people are buying these solutions. As we learn more about how this ties into the revenue cycle, how should revenue cycle leaders be getting involved with the selection of these systems? And I'd like to start, Nikhil, you want to kick us off?
I can. This is a great question. And I think maybe we could flip it to the audience real quick to get a sense. I'm curious if you're using an ambient technology right now. Can you raise your hand real quick in your organization? That's a lot of hands. Can you keep your hands up if your rev cycle team was deeply involved in battle testing and pressure testing and you were part of the selection process? A much smaller group.
3.
And I think it's consistent with what we are hearing in the market as well. And it makes sense, right? The genesis of this category was, how do we reduce pajama time for clinicians? But I think what that premise misses is documentation is a key input to the rev cycle. Every sentence that's written has implications for coding, for prior auth, for and if documentation is not written with those considerations in mind, then all of a sudden your teams in the back office have to, again, clean up that mess. And I think most folks in this room are familiar with the AAPC, one of the leading bodies on coding and CDI. They actually went out and interviewed a whole range of health systems. And what they highlighted was there's actually serious issues with implementing technology in the clinical workflow that's not coding aware. One of the organizations they interviewed is Cleveland Clinic. They are doing the Great American Bake Off across all the vendors. I think most of the folks here were being tested there. And I think they had the proactivity to include CDI and ref cycle very early in the conversation. And one of the things they found was for the vast majority of solutions, CDI queries and denials actually went up if you started to measure them. And so I think if you're in this room and you're thinking about the implications for your teams, I think one of the things you might want to think about is how do you engage the CIO and the CMIO, who are generally the buyers of these technologies right now, and help them shape how to think about the impact on the revenue cycle, make sure that that's part of the RFP, make sure that's part of the evaluation framework and the metrics you're measuring once these technologies are implemented.
Awesome. I'm going to tag you, Shiv, to see what you would add to that same question.
Yeah, absolutely. Agree with everything Nikhil just said. I think a core thesis that we probably all agree with on some level is that healthcare delivery is about people. Those people, they're having conversations, inpatient, outpatient, ER, urgent care. And those conversations are upstream of not just clinical documentation, but codes, orders we place, care management, clinical trials we recruit our patients into, care clinical decision support, experiences, ultimately we think outcomes. But I think a core insight that Nikhil just hit on is that in this country, we don't get compensated for the care that we deliver. We get compensated for the care that we documented that we deliver. So whether we like it or not, we're all rev cycle companies, and I think we're all on this stage because of that. Now, I think that, like, quick personal story. So I was on call this last weekend as a cardiologist. I used to be on a CDI team where we would go from clinic to clinic to clinic across UPMC, and we would try to teach doctors over PowerPoints and pizza how to write notes that could check off all the boxes from an E&M perspective, from an MDM perspective. Every single doctor in the room, 1,000-yard stare, they don't want to hear it. They just want to go back to caring for their patients. So we have this opportunity right now to actually take a lot of that burden off of their plates and help them just focus on the person in front of them, because we can help them. Over this last weekend, I saw so many notes where doctors would write suggestive of, or suspicious for, or history of. I think a lot of the coders in this room or people with that background recognize that these are red flag issues. I remember there was a patient that I saw who had a history of sick sinus syndrome, and it ended up as an ICE for the actual claim, that was going to go into this DRG for this hospital stay. Sick sinus syndrome and a patient with a pacemaker. So I had a question in my head: is that an active diagnosis? Pacemaker? Maybe this is spaced. The truth is it is an active diagnosis, because pacemaker doesn't actually fix something; it just sort of like gets you through something, mitigates something. And so these are the types of details that we should not expect our clinicians to have to memorize. When you extend this to even like prior auth, now we're talking about thousands of rules across all the different plans, across all the different geos. And so this is the opportunity right now to thread that needle for not just at an executive level, the CMIO who wants to see the roadmap, wants to see, all the different sort of use cases get done over time in all different settings, specialties, spoken languages. The CIO wants to see this integrated very deeply with the existing technology stack inside the system. We saw earlier how important the electronic medical record integration is. But then third, the CFO being able to demonstrate that ROI. I think already in what we're saying is a 4 to 6x ROI, and this ROI is immediate. And that's why this panel is so exciting.
Awesome. Thank you. So that's a great introduction to why revenue cycle leaders should be involved in these decision processes. Let me just dig one level deeper into that. What should these revenue cycle leaders be evaluating as they're thinking about these solutions? And I think it's been more clear on the clinical side, but what do they evaluate when they think about this? Punit, do you want to start us off there?
Yeah, happy to. I agree. I think ultimately these are two sides of the same coin. If you actually can be seamless in your clinical workflows, then it will impact revenue cycle automatically. I think if you're a leader who's looking at these solutions and asking, what exactly should I look at? Put that in 3 buckets. Number one, ask about the intelligence of the solution. It's one thing to just audio into an LLM wrapper and put out, no. But do you actually take previous data to actually into account? Do you take the context of the patient into the account? Do you take some of the work that doctors done before that into account to actually generate the kind of note that you create? So I would ask about the intelligence that's used. I would ask about what kind of contextual information is provided to the doctor at the point of documentation or point of care, so that they're able to make the right choices in terms of what they're doing. I would also ask about what kind of things are being documented. Is it actually dependent on the encounter or what the doctor actually probably made a choice to document? So those are some of the things I would look at from an intelligence perspective. I would ask about metrics. What kind of impact have you seen in your ecosystem where you've deployed in terms of revenue related to better documentation? Amended encounter decrease. I would ask about and similar things like that. And then finally, I think ultimately you can do all of these things, but it actually depends upon adoption. If there's no adoption, then ultimately, no matter how much these algorithms can be doing, they don't really do that. So what drives adoption? The classic SaaS adoption metrics are somewhere around 70% or higher in the market. As you've seen with some of the numbers, they're probably between anywhere from 30% to higher, 50% today in terms of what they do. So where are you deployed? Are you deployed across all form factors? Are you deployed across various settings? What specialties do you actually work on? Those are some of the things that actually also lead to changes in adoption. So I would talk about intelligence, I would talk about metrics, and I would ask about adoption.
Okay, thank you. Matt, what would you add to that? What else should we watch for?
I actually agree with a lot of Punit's points. I think the intelligence concept of making the models contextually aware is extremely important to making sure that you're able to capture all the visit types. But I think the last point was the most important, which around adoption. I think for us, Punit's right. Like, you won't get the ROI unless you're able to get these products adopted. And if you follow the typical adoption curve, you can see kind of, most deployments kind of settling and flatlining around kind of the 30 to 40% adoption in the early majority. But in order to actually go further down that stack, I think what we found as really important growth levers there is the ability to customize the models at the provider level. One of the things that, was very difficult for me to understand was, you can produce a note that's 100% clinically accurate, but the physicians are really going to still spend a lot of time editing those notes. And so really understanding how can you accommodate for those personal preferences and looking for the vendors that actually understand, what are the preferences that you guys have as an enterprise and how do you balance those customizations with the ones that the providers want. I think for us, that has shown, the biggest impact on being able to drive adoption. And I think, secondary to that, it's also about change management. I think we're here, all technology leaders, but one of the most important things in healthcare is how do you actually get physicians to trust you? How do you actually sit with them at the elbow and make sure that, they know that this is something that they can actually trust and use? And so aside from, looking at the efficacy of the model, you also have to really interrogate what is the change management process that the vendors that you're looking at are, and, are they just sending a link and having people sign up to the product, or are they willing to really, invest the time to go provider to provider and, implement these solutions? So I would say those are the two things that I would add to Punit's.
Fantastic.
Yeah.
Thank you. So I'd love to jump into how organizations can track success of these solutions. Now, I was on the phone with Dr. Hal Baker, CIO of WellSpan, the other day, and he tells me, he's like, look, I'm hearing from the physicians that this is great. They're high-fiving me in the hall. Like, this is great for them. But he said, I wanted to find out the true success. So I did a survey of their spouses to find out how things were really going. And he said the spouses were thrilled that these physician spouses were home for dinner. And I know that is not every case. This is not a magic bullet again, but just so many good sort of outcomes on the clinical side of being able to, again, be home for dinner. I'd love to understand how organizations can effectively track the impact of these tools. And Riz, why don't we start with you?
Sure. So first, I wanted to thank class for bringing us all together. Our political environment has not been to do that. All the time. Because finally, we're all on stage. Get pictures. So thank you again for letting us. So when we're thinking about outcomes, really need to partner with an organization that has the staff to measure the outcomes that are important to you guys. to define the outcomes, define what exactly what you're looking for. And so what we typically do is we're focused on looking at how do we make providers more productive, and we want making them more efficient. And what that translates into is probably, hopefully, more patients. It doesn't always happen. The second thing we're also looking at is the physician happiness. Is this really impacting their burnout scores? Is this really impacting the way that they're taking care of their patients and longevity in your organization? And third, the other thing that you need to pay attention to also is the patient experience. Are the patients looking at this as an intrusive product? Is this something that's capturing the information as a better note? All of us can see our notes now in my chart immediately. So is that note accurate, reflective of what's happening? So those three things are very important. And so you need an organization, like a customer success organization. Most of our hospitals don't have the staff to do these metrics analysis. So you want to partner with an organization, vendors like over here, to say, hey, you have the staff to do this. These are the metrics that are very important to us. And we try to focus on those and deliver those using survey data, using signal data, using EHR data. And lastly, so when you do it right, you do those kind of things right, what you see often is you see results like where providers like at WellSpan, they're seeing more patients automatically without being asked. It's hard to say it to somebody, here's a tool that will make you happier, but can you see more patients? Can you document that? It's not a very good argument to make. So we want to do this. We want to give them a product that's easy to use, automatically improve the resilience so they can go and see hopefully more patients if it's possible, not always. And the second thing is also measure their satisfaction and burnout, measure it objectively. And lastly, also measure patient satisfaction. So get a measurement of that. And so we're seeing that across WellSpan. We're seeing that across multiple organizations now that they're actually seeing more patients, less spread out, and the patients feel like the experience was better than obviously the
Thank you. Ian, what do you have to share?
Well, for one, I want to agree. We've definitely saved lots of marriages and lots of retirements, and I think that's probably true for all of us, and it keeps us going. I mean, the key thing that keeps coming up is metrics. So for one, we need all of you in the room when those initial metrics setting, expectation setting meetings are taking place. They can often be oversteered by the CMIO and the CIO, and then you're brought in months later, and it's really hard to change things. So initially, oftentimes the metrics are all about, 1-2 hours of time savings. How do we prove that? And we generally do prove massive time savings. And then there's an expectation that with that time savings, maybe see more patients per day in certain circumstances, and our job is done, and let's go execute that. But there's so many other metrics that matter a whole lot as well. In particular, metrics around documentation quality, coding optimization, and the hospital setting, which is coming up quickly, denials and denials management. And what we're seeing in our deployments is those later metrics that I've just described are actually the superseding and prevailing metrics that support ongoing expansion, contrary to the initial discussion, which was all about seeing perhaps more patients per day. I believe that is achievable in certain settings and certain specialties, but not all. So we need a much more nuanced conversation and partnership. And another thing I would say is you should be turning us into your McKinsey on demand, basically. So we're showing up, speaking the same tune, showing the same numbers, and to some degree at risk with you so that our expansion is contingent on your success.
Awesome. Ian, thank you for that. And before I get to you, Shiv, I was with the CIO the other day who actually pulled up their dashboard and showed me. They said, look, we're getting $18 per visit more than we were before, which goes right to the bottom line. Most of our physicians are seeing 3 to 4 more patients a month than they were before. And again, we're not asking them to do this. This is just a very natural sort of outcome of what's happening. I talked to another CIO who said we're seeing 8 more a week. I was a little, maybe a little more skeptical of that, although I think it's absolutely possible. But Shiv, what would you add to the metrics that we should be looking at here?
I think we're all in violent agreement here. I do think it's really important to bring rev cycle, bring the CFO's team in as early as possible. But what Punit said is also really key. You build all of this by first being able to get into workflows, being able to actually unburden clinicians, because that is a public health emergency right now. We have 2 out of 5 doctors who don't want to be doctors in the next 2 to 3 years, and 27% of nurses who don't want to be nurses in the next 12 months. And so finding a way to first and foremost, I think, ensure that we, collectively are measuring how well we can integrate and how well we can get adoption. Are clinicians using this technology for all of their encounters in all the different settings? And which clinicians? Is it across all specialties? Is it across all settings? Or are there any edge cases? And then at the same time, being able to measure, to Ian's point, I think the harder ROI story here up front, because that's how you end up expanding.
Fantastic. Thank you, Shiv. Nikhil, you'll be our last one on this topic before we move forward.
I think I agree with a lot of what was shared. I think adoption really matters. If you don't have adoption, you have nothing. I think that's probably everyone on this panel and everyone in this room can probably agree on that. But since this is more of a rev cycle focused audience, it might also be helpful to talk about the specific rev cycle related metrics by specialty that you probably want to start thinking about tracking as well. And I think part of the way we think about the role of this technology at the point of care, it's almost like a tale of two cities. Either you've got technology that's collaborating with the clinician to get better visibility into what's happening at the point of care, as well as nudging them to document in the more precise way that's necessary. Or you got technology that's not, and you don't necessarily get the benefits, and potentially there's negative impacts on your KPIs. I think there's some high-level KPIs that were talked about earlier, CDI query rates, denial rates. Those are things you're going to be able to measure across pretty much any specialty area for the most part. But then I think one of the things we like to do when we work with an institution is also think about, in every single one of your service lines, what are the exact metrics that you should be holding us accountable for by that specialty? So in primary care, for instance, it's probably going to be a mix of E&M mix, modifier 25 utilization, add-on code utilization like smoking cessation, and then compliant HCC documentation and capture as well. So that's the primary care setting. But that's going to look very different from the metrics you want to measure in the ED. So that's going to be level of service mix, critical care capture, procedure code documentation. Some of you are probably in pay-performance contracts where quality metrics matter. So patient comes in with chest pain. Did you actually document the New York Heart Classification level for this particular chest pain? And if not, can you nudge the clinician to ask the right questions to get to that documentation? All those things matter. And I think one of the things we're seeing is that if you get all these pieces right, you don't actually have to ask clinicians to see more patients. It's a nice to have. But you'll see on the order of tens of thousands of dollars of ROI, and that's a contribution margin. That's measured on the P&L in 6 to 12 weeks if you get all this right. And I think you should hold vendors accountable to that. And I know that there's probably, for every service line, there's probably dozens of metrics, so that's a deeper conversation. But hopefully that gives you a sense as to the level of specificity that I think you should hold the folks here on this panel accountable to.
Thank you. One of the things I like most about this panel is it feels like it's us against the problem. Like, this is a huge problem. It's been a problem for so long. It's like, how are we going to solve this? I love that. And I'm going to ask a question that may break that harmony. But I want to ask it very carefully because I did just get a text literally from Trump asking for $5 more. So I know that the political spectrum has not been this.
Time is running out.
This collegial. But so I want to ask the question of what differentiates you in the market. And I want to be clear that I'm not asking for you to beat up any of your other competitors, but what is it that makes you unique in your ability to solve the problems and get to the metrics that we've just described? So we're going to start at this end, Riz, and we'll go down the line if that's okay.
Yeah, absolutely. So what differentiates us as Microsoft? So we're a big company, and we're focused on the data. So the data is the key. And one of the artifacts that you're seeing from that data is the note and the quality of that note and the documentation. So we're all here trying to, the first panel that we have, the clip that we have is how do we break down these silos of data? How do we break that down, combine the data? So now you have the opportunity or the ability to take this data, have it available, and break down some of these silos and apply AI to solve and automate some of these problems. That's one of the big things that differentiates us. The second thing I would say is partnerships. So we know we're not the smartest people on the road yet, right? We know that at least I'm not. So a lot of these guys are. So what we want to do is we want to partner with the smartest people and open up a platform where you can connect your data and the best of breed and bring that into the node, into the workflow. That's a big differentiator. And the third thing I would say is have a clinician experience. You see so obviously on this stage of clinicians, having that to make sure the first step is getting adoption, getting your product being used to use it, the clinicians and actually the doctors. So having a clinician company or a focus, or then looking at the clinical experience, the those are the frontline workers that to use this product that will lead to the downstream benefits as well. So that's how I would explain.
Great, fantastic, brilliant. I think that I would say for myself, I feel that I'm not competing with solving. I think we are all competing against the status quo, and for that we should have a lot of respect for all the work that's happening on this stage and side of it. The truth is that we started building Suki at the time from ground up, based on this idea that there would be a knowledge graph on which there would be lots of models and AI first design on your features. And over time, AI progresses and people can build actually products that look almost like very close to a really awesome demo. But the difference between a really awesome demo and something that's actually deployed, that last mile, is where actually everything matters. So the precision with which you actually look at workflows, how they blend in, where the content goes, when you actually talk about metrics, how are they actually measured? How is actual change management being done? The last mile is usually where the differentiation is. And so for us, the four pillars that matter are, number one, we are an assistant. Clinical documentation is the skill of the assistant. It's one of the things we do, but we do a lot of other things along with it. Patient summarization, orders, so dictation, Q&A, etc., etc. Number two, we actually work across all major EHRs. We have deep product and commercial partnerships with Epic, Oracle Health, with Meditech, with Athena. Number three, we actually are a platform. So a lot of other people end up using us. For example, the largest clinical communications company in the country, Vocera, with those nursing badges, their next badge is actually powered by Suki, deployed soon across 1,400 health systems. We just announced Zoom, which basically is 40% of US telehealth using Suki. We have a Suki EHR program where 10 EHRs in the long tail are actually using our SDK to embed intelligence into their product. So you may be actually using us, you just don't even know it. And that's probably the biggest differentiation of all, because ultimately our goal is to become an AI engine for healthcare. And all of these are different ways we can accomplish it.
Fantastic, thank you. Matt.
Yeah, I just want to point out, I think all of us on this stage have been doing this for a really long time. And I think we all have kind of been down the rabbit hole long enough to kind of look at the problem that we're solving as not only documentation, but in how do you actually harness the true power of the conversation data that's being processed. And I think, for us, we really focus on what we call the ambient operating system, right? What can you actually do with the conversation data that you're harvesting? And I heard a lot, from the two speakers that just shared the similar vision. And so, I think it's really important that we're all kind of looking at the future of what we can do with this data. I think for us, the biggest differentiation is okay, what are we actually doing with this data? Do we have products out in the wild that are being used by hundreds, if not thousands of clinicians that are actually leveraging the power of these conversations, right? So, I think it's important to have that vision, and it's important to find that right partner that partners with you to figure out what is the actual, use case that you want to do with the data. But, do they actually have a track record of actually delivering on that promise? Aside from that, I think we all kind of acknowledge that adoption is immensely important. Right. I think not just adoption, but also what is the depth of the actual engagement that you actually seeing from the user. So, for us, we've been able to, I think we lead the industry in terms of being able to customize the notes. It's not just changing the pronouns that you refer to the patient as, but being able to upload, custom physical exam, custom macros, being able to write your HPI by pros and your plan by problem in bullet points. Now, doing all of these things, I think, really allows us to meet the providers where they are and are able to generate, higher levels of adoption. And backing that up with, a really best-in-class team to sit at the elbow with all of the clinicians and really get them to trust the solution and help them customize that model. It's one thing to just give somebody technology, and it's another thing to walk with them and walk that line and make sure that they get through the door and they're safe along the way. So
Great, thanks, Matt. Ian.
Yeah, so I'm actually surprised the word table stakes hasn't been said today. I feel like I hear that constantly. You'll hear that AI note-taking is increasingly table stakes. It's somewhat true. So our response is this. We here at Augmedix, we invented ambient documentation, and we're going to now be the first to destroy it. Our job, we see it, is to quite literally blur the lines between ambient note-taking, RCM, patient engagement, Internet of Things, networking, and sensors. And now that we're combined with Chimera and the general Catalyst engine, which actually has a full-blown frontier RCM and engage and strongline capability, we're really able to do that. So if we're deployed in the future and you can't tell a difference between where ambient ends and something else begins, our job is done. So we are a huge differentiator for us is to very pointedly become a platform and get out of the narrow lane of being that point solution, note-taking solution for you. So that's probably our biggest differentiator. The second one is, people think about ambient documentation as like a one-way street. Doctor-patient conversation takes place here, node ends up over here, done. We think of it as a two-way street. It's incredibly important that in the other direction we're in workflow, elegantly nudging the provider to do things regarding patient safety, CDI, CDS, at the point of care upstream so that downstream things are taken care of. And we're very much all about doing that. And in particular, we're doing that in the hospital setting where those interventions really have incredible ROI and knock-on effects. And a large reason we're doing that is because of our key partnership with HCA, which is very much focused on the hospital. You probably saw last week, we just announced our enterprise-wide exclusive agreement with HCA, and that, in a lot of ways, that drives our focus area from here.
Thank you. In fact, I think I can see a T-shirt coming. Augmedix, destroying documentation. That is
Hold me to it.
Nikhil.
This is a great question, and I think I'll echo the sentiment, which is for all of us, we're here because we saw a big pain point for ourselves, our loved ones who really wanted to take care of patients when they discovered the practice of medicine may not fully be that anymore. And so for us, a lot of our ethos is obsession over adoption, obsession over driving real impact and real results for the organizations we work with. And I think it boils down to two really big pillars for us. The first is specialty coverage and getting true adoption across specialties. Most of the organizations we work with are large health systems. They're home to dozens of ambulatory specialties and subspecialties. They have emergency departments. They have inpatient settings. And they don't want to necessarily work with a bunch of different point solutions across different settings of care. They want one partner who can service all of them. But as you can imagine, that's a hard task because the medicine in every specialty area is different. The reimbursement frameworks are different. That has implications for documentation. And so you've got to solve that. But then on top of that, the workflows are also incredibly different across these settings of care. You think about the ophthalmology department. It turns out there, the bottleneck is actually the tech workflow. And so you need a product for the tech to actually drive ROI for the department. In oncology and most of the subspecialties, 80% of the work in a follow-up visit is actually pre-charting. So if you don't have a pre-charting solution, you have a broken workflow, and that hurts adoption. And then in the emergency department, you think about the interaction. It's not a one-to-one conversation. It's a visit over 6 hours. You're balancing multiple patients. You've got consults with the paramedics, the consulting specialists. You've got timestamp requirements for documentation. You have to obsess over every single one of those details to achieve meaningful adoption at scale across the health system. And I think that's been one of our calling cards. We're live now across 100 plus subspecialty and specialty areas at UCSF, including now the ED and soon the inpatient setting. We're live in 40 plus subspecialties and specialty areas at Cleveland Clinic. So I think that's one area of obsession that's been big to us. The other for us is integration. Ultimately, these products have to actually drive value by changing the right things in your system of record. And some of those are challenging. So you think about one of the things we talked about today is HCC capture. That requires us to write back ICD-10 codes into Epic. Turns out visit-level diagnoses are hard to write back because every institution has a ton of customization in your EDG records. And so you need these models to be able to read these EDG files, normalize against your instance's diagnosis universe before writing back. It's the exact same problem that you've got to solve with orders. And recognizing that those problems may be hard, but they're critical to achieving ROI has been sort of our philosophy to say, it doesn't matter if the technical challenges are hard. If it drives adoption, it drives ROI, then we'll focus on it.
Thank you. And Shiv, we'll give you the last word on this one.
Absolutely. The last few years have been historic, I think, for all of us. We started our company in 2018, and I remember at that moment in time, we had a deck, and we didn't know how long it would take to actually get to where we are, but there were several years of just sort of figuring out how to eat and digest glass. until I'd say like 2-3 years ago when things started to pick up. Over this last year and a half especially, I think what's been so incredible to see is like many sort of puzzle pieces coming together, many stars, some unfortunate, like the public health emergency around burnout, becoming top of mind for executives around the country. For what that's meant for us is sort of, it's been this opportunity over time to figure out what it takes or what it means to be healthcare grade, in our estimation. And in our estimation, it means that we have to have that science at the center of our company. We have to be on the absolute cutting edge of what's going on, especially in this moment with AI and how fast things are moving. You always want to be leveraging the latest and greatest so that you can deliver the latest and greatest to the end users who matter, clinicians and of course patients. But in addition to that science at the center, you need that, I think, domain expertise. And so for us, what it's meant is making sure that we've got doctors, we've got nurses, we've got PAs, we've got coders, we've got rev cycle experts working across every single part of the company. One of our machine learning engineers is an associate professor of pulmonology, and this is what he does now full time, is working alongside others to ensure that we can deliver something that is enterprise healthcare grade. I think in healthcare, what's different compared to, say, legal, where there's a lot happening right now, is also with these sorts of like opportunities around generative AI or call centers for other industries, is trust means everything. And I think in our estimation, trust is some combination of transparency, reliability, and credibility. And so for me as a doctor, it means not just publishing papers, not just working alongside Epic to build those signal dashboards that can give that transparency around how things are working. Credibility in terms of being able to demonstrate, as well as others on this stage, that we've been able to scale across the country. At Kaiser, we're live across all the different specialties. And the same is the case across Emory and Yale and Sutter and any number of health systems across the country. And we've learned the same things. It's that the devil is in the details of workflows. And to me as a clinician, the ideal user experience for this technology is actually like good air conditioning, where when it's set right, you're not aware of it. I don't want any new nudges. I don't want any new paper cuts. I don't want an actual UI per se. I just want as much as possible to be taken care of for me so that I can just focus on the most important person, the patient in front of me. And so that takes a deep relationship that we've been able to earn over time in relation to how we integrate with medical records like Epic, where we're in the workshop program. But also it takes being able to, I think, demonstrate that it's about the metrics that we were speaking to earlier. So as an example there, being able to have these admin dashboards where transparently folks who are partnered with us can take stock of how things are working, how much time are people saving, how much time are they spending in the medical record, and how well have we done on orders. I think that transparency means everything.
Okay, thank you. And thank you for that clarity of what you're really focusing on today and how you differentiate yourselves. I'd like to jump into the future for a minute. I know it's been fascinating to hear organizations I've talked to say, man, we've really done great in this space, and now we can't wait for them to do this next thing, which feels like, again, the second miracle that you need to tackle and do it quickly. So where to next from here? And Matt, why don't we start with you?
Yeah, I think you saw on the slide earlier today that there's many health systems adopting Ambient today, and I think if whether it's DeepScribe, whether it's Abridge, whether it's Ambience or Suki, I believe that in the next 3 to 5 years, 90% of all patient conversations are going to be recorded. And I think in that reality, we really need to start interrogating the question of what does care actually look like? What kind of data is present in a world where all these conversations are recorded? And really try to figure out, are there ways that we can apply this technology to actually surpass what is humanly capable today? And so, I think, in this room, I think we have pretty well-defined roadmaps based off of problems that are really, right in front of us, right? I think a lot of us are working on nursing documentation. A lot of us are working on order entry. A lot of us are working on, being able to put discrete data into flow sheets. I think, you're also seeing really amazing stuff being done, taking kind of the RCM lens and bringing CDI, doing charge capture into the workflow. I think more in the kind of the medium term, you'll start seeing a lot of the like specialty specific use case that Nikhil was referring to earlier really emerge. at DeepScribe, we have over 1,000 oncologists that use DeepScribe every single day for their documentation. And because of that saturation, we've actually built a lot of, functionality on that spectrum. So, using the data to accelerate trial recruitment, using the data to grade and measure adverse events, using the data to streamline the care operations. So I think in the medium term, you start seeing a lot of these specialty-specific use case. And then I think in the long term, I think one of the things that I'm personally really excited about is actually being able to leverage the voice. So not exactly like what is being said, but how it's being said, right? I think there's a lot of really interesting companies out there that are actually able to diagnose, PTSD, anxiety, depression using, a vocal biomarker. And so you can think about a world where you're able to actually take these voice conversations and actually help the physicians provide care that they would have otherwise not been able to provide. So I think the future is really exciting for us. And to Nikhil's point, like the ROI for ambient solutions, it shouldn't be to convert the time savings you save for the providers to have them see another patient, right? There's so much value that's just trapped in the conversation that I think it's up to us on this panel to really harvest, and we can do that and make seeing increasing volumes, having more patients really a choice. So
Thank you. Love that visual of the future. Riz, what would you add to that?
No, I would agree. So the way we see the future is almost like the Star Trek room of the future, right? You walk into a room, you have smart devices that can recognize you, that can hear you, recognize your voice with biometric sign-ins, and then have a conversation. And the way we envision this is in a trusted, responsible AI environment where the AI has been trained on responsible AI principles and also in a secure environment. Plus, on top of that, we're looking at 4 key areas that we're focused on as part of the future is making customization to the individual provider a core feature, making more and more customizations available for the individual user, automating things that can be automated, like things that the physician doesn't have to do, or the provider, the clinician, or the nurse, things that they have to do. How do we automate that automatically without having them to click a button or do something, similar to what Shiv talked about? And also to look at infusing knowledge into that workflow. So as you're doing this documentation or talking to the patient, how do we infuse knowledge right into that workflow? Maybe it's a clinical pathway, maybe it's a recommendation, but how do we do it without disturbing the provider or the clinician experience in a way that's very natural for the provider? And lastly, this is just the beginning, right? We're just starting on this journey, and I think everybody here recognizes this. We've heard the word platform a lot. Microsoft is a platform company, so that's what they're focused on, is opening up this data for everybody, right? So you can have your own data, you can use different AI models, different things that you can do, and really create a platform that you can do many things with that data and open it up in a trusted, responsible, secure environment.
Thank you. Punit, what would you have to share from the Suki perspective?
Pre-electricity, post-electricity. Pre-internet, post-internet. Pre-AI, post-AI. And I think anybody who doesn't realize that we are in this moment of transition is, out there at this point. Post-AI, a whole new set of winners are going to emerge. A whole new set of losers will also be there. The whole world's probably going to be rebuilt in terms of effectively a data layer that's a knowledge graph that's structured and has a relationship to each other. On top of that will sit tons of models of all kinds, tuned for a variety of different things. And on top of it, there will be AI-first UI, which will not look anything like all the stuff you are checking, clicking, ticking boxes today on. It's not going to look like that. In the healthcare world, that means a clinical knowledge graph, an LLM language model manager that actually can manage different models for different use cases. AI-first UX, which actually may not be UX at all. It may be, I think the word that was used was invisible and assistive. This is inevitable. It's going to happen, whether we like it or not. So if you think about that, of course, we will build more skills into the assistant. Of course, we will build it for nursing. We'll build it for staffing. Of course, there will be more and more platform features that will be exposed to all sorts of healthcare tech companies in the world. But ambient is not just speech. Ambient is going to be video. Ambient is going to be what you see. Ambient is going to be all the contextual data around you. All of that comes together to actually build a whole new experience that's going to be built. So we are basically in like phase one of step A of this. And in that world, what does RCM do? I mean, wouldn't the best thing be if you could actually just see the patient, have all the information, all the data fumes go out, and people get paid immediately, instantly? That can happen and will happen when you take this ambient AI and plug it into a financial engineering model. And I believe that in the next few years, you're probably going to see the first versions of these things pop up. Hopefully, we will be a part of that story too.
Can't wait to see what this looks like. And by the way, I saw that Oracle Health announced today their new EMR that's going to be launched next year. They will have no drop downs, no check boxes. Like it feels like it's just going to be all speech. So I can't wait to see what that looks like in this post-electricity world.
Whether they win or not, the idea is right.
Yeah, the idea of moving that
And I think
direction.
EHRs will have to rethink themselves. And by the way, all these services, people-oriented, human-in-the-loop setup that we have right now in the RCM, I'm sorry, it's going to collapse. You basically have to redo it with AI. So,
Okay, Ian, you get the last word on this question.
Oh man, I really like that sort of invisible assistive combination word you just said, Punit. I mean, if I look back a couple of years ago, the ethos was about sort of automating the human scribe. I think we're now at the stage where we're supercharging the doctor and the provider, but in a sort of assistive, invisible way. So increasingly I see our providers are seeking help and thinking through their complex MDMs and their differential diagnoses. That's where we're starting to play now and where I'm really excited about. I also kind of align with what you said, Punit, about sort of, and we were talking about this earlier, ambient everywhere. All devices, all platforms. Things are going to get blurry and blurry in a good way. And I'm really excited for the future to be part of it.
Fantastic. Well, I'd like to just take a second and recognize how miraculous it is that all 6 of these individuals were able to make it here today, for all the work they've done building this over many, many years. I know many of you are founders, have been thinking about this and working on this for years and years. Let's just give them a round of applause for their work. So this is we're going to go to the open mic section. Would love to hear what questions you have for our leaders here today.
How you doing? Jeff Studenko with Omega Healthcare. Great panel. I noticed a lot of the conversation was around healthcare delivery and how AI will impact that element. But as many of you are physicians, I mean, take AI a step further. How will AI impact healthcare from a patient perspective? And how do you design into that model versus keeping the way we do healthcare today static? What implications are there?
Who wants the first swing at that?
I can take the first swing at that. So we're looking at, we're just on the beginning start of this journey. So what if we could imagine, instead of treating patients after a disease happen, what if we could use AI models to predict and prevent some of these diseases from happening? So that's really we're starting on that journey now to get the data all unified into one platform where you have the ability to look across the different silos, break those silos, apply different fine-tuned models or AI models that are designed to solve certain problems, and also to help with preventive care. I think that is really where there's a huge opportunity for cost savings and a huge opportunity in our managed care environment. How do we decrease some of the expenses? Because, what we're doing is not sustainable, and it's just not, right? So we have to completely change the paradigm and really apply some of the data that's available in our EHRs, data that we're collecting in all these different sources, and really change it and go to more of a preventative approach.
Well, Shiv?
I think that one thing that we're at Abridge, we're continually reminding ourselves about is that we are operating still within the rules of the existing healthcare system. And within this system, is there a near-term world where we've got AIs battling AIs, provider AIs versus payer AIs, and we're just like in this continual game of who can one-up each other? It's possible, but maybe one conclusion of that is that we get to this like better nirvana state that Punit's speaking to, where we've got this clinical data graph and we can start to identify and prevent conditions before they even come on. And so I think that the speed with which technology is moving right now is superseding the speed with which government is moving right now, with which policies are moving. And over these coming years, it's going to be really wild to see like how we can start to converge and get better alignment.
We have one other that wants to take that, Ian.
You remind me of some things that Dr. Schlosser at HCA instills in us, which is please don't come into HCA and just cement and amplify the processes that we're already doing. Reimagine documentation, please. Reimagine healthcare, please. So I ask you to hold us to that when we come into your health systems. Don't just have us amplify the status quo. What is a note? Why do we even have a note? What should replace the note?
Can patients help create these notes, even upstream of an actual clinical encounter?
Okay, next question.
I have you just about answered, I think, but Adam, you moved the conversation over to the future, and Ian, you started answering, but I was thinking about as you get your arms around, the AI gets their arms around all the elements to a claim that gets submitted to a payer. I'm not hearing anything about working with the payers so you can integrate all that into an almost instantaneous adjudication of a claim. And the second part of the question is, as we leave fee-for-service and move into a more risk-reward arrangement, so the big bucks for the provider gets earned when he keeps people healthy rather than treating sickness. So that's the other thing that I'm still trying to figure out about how thanks.
Punit?
Yeah, I wanted to react to that. I think one quick comment to what Shiv said. Imagine a world where there's an agents as in AI agents representing patients, agent representing doctor, agent representing a peer. You find out that you're probably going to get sick. The agent actually gets your permission, goes out, looks at all of your financial information, figures out which doctor you should be talking to, exchanges information through a decentralized backbone of data. The agent of the doctor gets all the information, sets everything up. Now you actually have a conversation. Agent pays attention, everything is created, all the information goes to the right place. You get everything you need to get healthy. The information goes on to the payers. They do the handshake and automatic payment happens. Yes, of course, this sounds like a mirage. It sounds like mythical that this can happen. But to your point, if you really want to take on and think about what rethinking of RCM looks like, in my perspective, there are three entities here that have to work together. The ambient intelligence has to be deployed in healthcare systems, but has to actually work with the financial engineering that something like a payer model can provide, such that all of this moves seamlessly. People see people, people get paid fairly for high quality care. So I think this is inevitable, and it's probably where things will go in a few years.
Nikhil, do you want to add something to that?
Yeah, I think maybe the one thing that's exciting is I don't know that this is that far away. I can give you an example from an organization we're working with right now. And AMC has been fighting with a payer on prior auth for a couple of years. And one of the things they brought up was like, look, we'll fight and we'll fight and we'll fight. But the reality is for a number of these therapeutic areas, you always decide to adjudicate. Why is it that we keep wasting resources and fighting? And so one of the things we're already seeing is that AMC's come to us to say, all right, here are the therapeutic lines that we care about. Here are the denials that are coming up. This is what the payers told us. If we can guarantee documentation of A, B, and C things consistently in this way, we won't fight you on it. And so I think, in some ways this sounds like a crazy far out idea, but I think actually folks are realizing that we're fighting unnecessarily on many things, and it's waste on both sides. And I think we're going to start to see these paradigms play out in a larger fashion across the industry, and it's probably within the next 12 months, probably not years and years and years away.
Great. Let's go to the next question.
Hi, I'm Sarah Rahman. I'm the ACMIO at Alameda Health System Safety Net in Oakland, California. And I have to applaud the 6 men up there. Your vision has been driving this forward in a way that has changed healthcare to date and will continue to change it. And your visions are going to drive it in a way in the future that we can't even imagine. So my question to you is that we are moving into a new phase where business vendors are driving change. And when you have the mind, the brain power that's sitting up there driving change, I want to see diversity. And there is some diversity, but I think there's also women that need to be included, very frankly, because there are differences in how women practice medicine. We know that from signal data. There are differences in patient outcomes when women are practicing. So in this very rapid development, I want to know how you are incorporating those other voices in your developer phase. And the second part is from the patient perspective. Again, we're a safety net. We don't have a lot of money to spend, and we don't have data analytics. How are you addressing those patient voices for our non-English speaking languages? We have over 50% of our population is non-English speaking. We have low literacy levels. We have, just refugees, substance use patients, et cetera, et cetera. How are you making sure those voices are represented? So really, the two parts of the question in the diversity, equity, inclusion, how are you addressing that on the developer side as well as the patient voice side?
Thank you for the question.
I can pop in. On the first point, we here at Augmedix have signed the parity pledge, so that we're always taking a look at diverse and female executives and leaders with every hire that we make. And on our board, we have two females on our board, and as well as other diversity. We take it extremely seriously. And when we think of diversity, we also think about global diversity. As we go live in other countries, we're doing deployments in the Middle East, other parts of Europe and North America right now. It's a much bigger question. How do we think holistically? And we take that seriously as well. And to the point of languages, I think we're doing two deployments now that involve Haitian Creole. So I can just tell you that we're putting a whole lot of resources into directly addressing these questions. We take it very seriously. I'd love to hear what others say as well.
I can speak to this a little bit too. It is really, really hard to build technology for a population when your organization doesn't reflect the diversity of the population you're managing. I think that is 100% true, and for us, that's been a driving factor of how we think about growing our team and recruiting. I think 60% of our organization comes from diverse backgrounds. I think every organization up here probably will say that there's more work to be done, but I think it's really, really important. On that note as well, we've thought really deeply about how do we partner with organizations who are serving underserved populations. So one of our first partnerships was with an organization called MIDI Health, which I think is part with many of the large groups here to basically provide perimenopausal care to patients over the age of 65, perimenopausal care to patients who are struggling with hot flashes and all the other aging-related issues that come up. We also work very closely with a number of groups in the South Florida market where conversations, you might have a physician speaking Spanish and a patient speaking Portuguese in the same visit to each other. And these technologies have to be able to manage that, produce English documentation, and also produce a Spanish or Portuguese after visit summary for the patient. So those are environments that we're actively building in. We work with a couple of institutions around yours, including John Muir, I think, which is sort of across the road. I think some of the challenges there are a little bit trickier. So we're currently working with some of the state regulatory bodies to figure out what is the process to get the technology certified, because one of the things that's come up for us in regulatory due diligence is that we can't produce a Spanish after visit summary for a patient, for instance, unless there are certain checks and balances that are in place. We're actively working with that, working on that in the state of California. I wish we could get there faster, but your point is heard. And I think it's a really, really good one.
Yeah, I might add too, I think it's the same sentiment as my colleagues. I think it's about the people in the company, reflecting the people who we serve. It's about the people around the company as well. It's about investors. It's about our partners. And we've been able to learn so much from systems like CHCF, from OCHEN, from Ultimed. Right now in California, there will be tens of thousands of conversations today, probably in Spanish and Mandarin and Vietnamese. Today, in Boston, there will be conversations in Haitian Creole and Brazilian Portuguese. In Indiana, there's a doctor speaking Punjabi to her truck driver patient population. We're creating English notes for all. But to echo what Nikhil said, like as much as we want to create those notes also in the native language for the patient, there's compliance issues that we're also, I think, collectively trying to navigate through. So 100% agree with you, and we can do more. We can do more over time.
And thank you for that question. I think it was a good one. Also, just know that at class, we almost always have diversity on our panels. This will be about the only one you'll ever see 7 males on the stage. But at the same time, trying to get to the founders, the CEOs, the leaders here. So just know that was part of our conversation before we did this. So I think we have time for, let's take one more question.
Okay. Hi, this is Navneet. I'm Chief Product Officer at Infinix. And maybe the question is directed at Punit, but everybody else can add to it, which is, and maybe this is slightly provocative because in an agentic ambient data structure-based environment, why do we need an EMR?
Okay. I think that what we call an EMR today should not be confused with the incumbents and the power imbued in them. There will be something that actually does the work of an EMR. There will be a database, a data structure. There will be a set of policies and regulations. There will be the manifestation of that into whatever the financial work it has to do. Whether that looks like the companies that are EMR leaders today, or whether that looks like the EMR user experience that looks like today, it's up for debate. I think the question for the EMRs, the companies that are leading today, is can they reinvent themselves to be in that world? Because just like Sears probably thought pre-internet that it's inevitable that they're always going to be there, that they are the market leaders, and then they just poof, vanished. Some will, and some will not, and some will be able to keep up. So I do think there will be something that will do the work. It'll look very different from what it is today.
Yeah, I think I agree with the sentiment, but I think you're already seeing that to a certain extent. You're seeing that where you're seeing AI being embedded in the EMRs themselves to automate things, and the experience is changing. So right now, like Epic is embedding AI into their workflows for chart summarization, in-basket messaging, things that we do manually, orders, those kind of things are changing. Still keeping the information there for other purposes. But you also saw just today, Cerner just announced that they're creating a new EMR, which is not an EMR. They're building on a completely new class and trying to automate things, use voice, use ambient technology with speech and vision and other forums to automate things. So you will definitely see an evolution of that. It'll take some time, but it's a good question.
Anyone else want to hit that question? Should we do one more? Like, I love this. I could just eat this up all day. So can we do one more question?
Thank you all for being here today. My name is Jay Verdorn. I'm the Chief Information Officer for Revere Health. We're the local boys here in Utah. My question is a lot of the conversation has obviously been around optimizing existing revenue cycle models. Either in the documentation and making it more complete, charge capture, auto posting, order creation. What about the value-based care world? There's a reference to the idea of full risk. I'm wondering, as your products are today, is there examples of where you've been able to successfully help an organization that's been value-based care centric? Meaning that, helping with the HCCs, attacking quality metrics, the areas that evolve around our current ACO models and such. Any examples that you could share with us on how your products are helping those organizations? Thank you.
Yeah. I think I could take a stab at that one. So, one of our customers has over 700,000 MA lives that they manage. And when we were kind of going in the running for, that business, one of the things that they were actually measuring was HCC degradation. And we were actually going head to head with another one of the competitors that are sitting on this panel. And throughout both of our products, what they've noticed was that there was HCC degradation through the ambient documentation that we were creating. And so one of the things that we did was we partnered with them to essentially design and co-develop a product that is now launched, to the general public called HCC Assist. And what this does is we essentially look at the problem list and we identify all of the HCCs that need to be recaptured for that specific patient. We have a drawer in our app that allows the physician to actually look at, what are all the HCCs that need to be recaptured, what are all the HCCs that are suspected, and then what's really awesome is that we're able to listen to that conversation, and we're able to evaluate the care that was provided against meet criteria. So the physician was live during the conversation can actually see, are they actually compliantly capturing this information? And then we're also able to kind of, to Nikhil, and some of what Nikhil is doing is like bring the CDI upstream and making sure that we're documenting the care in a way that's actually compliantly capturing those codes. And what we've seen is really amazing results with this. This product is deployed, almost entirely across that entire MA population, and we've been able to increase recapture rates by over double digits. So,
Nikhil?
I think these are amazing points. And I think if there's one more thing to add, it's that when you get this right, this is actually where 80–90% of the value can actually come from in value-based care. I think we work with probably some of the largest VBC players in the country, from Millennium, Mosaic, for folks in the health system world taking on risks, St. Luke's up in Boise, Idaho. And I think consistently what Matt's describing is exactly the largest value driver for those organizations. The second component that's actually potentially more interesting than just HCC capture is thinking about primary care redesign. Because if you think about, if you're actually taking global cap risk, the other question is, how do you actually meaningfully bend the cost curve? Because at some point, that's a game that you can play for the next couple of years and you'll max out. But then the question is, how do you actually meaningfully reduce cost? There's a couple of groups that we're working with right now where the question is, with these capabilities, how do we turn an episodic interaction with a patient into a much more continuous conversation? Because these agents can actually enable you to interact with your patient population on a much more regular basis than waiting for them to come in 2, 3, 4 times into the visit. I think it's too early to say what the results are on any of that, but I think there's a lot of really exciting work to be done for groups that are actually taking on the hard problem of bending the cost curve.
Shiv?
Yeah, we spent the better part of this year going deep on this with Kaiser. And at Kaiser, what's been fascinating is that they have such a well-oiled machine around all things related to value-based care that we've been able to sort of build technologies that sort of assist and augment what they're already doing in the first place. But one of the concepts that we're in the throes of right now is not maybe clinical documentation improvement, it's more like clinical conversation improvement. How can we sort of be able to pull past medical history, pull problem lists, pull those CCs, and then be able to nudge the clinician on maybe what conditions they should speak to in the conversation they're about to have with their patient. But beyond that, I think beyond being able to check off the box on like the CCs, the chronic conditions that you need to speak to as a primary care clinician, I think the suspected game, or the suspected story opportunity is really fascinating. As a doctor, if I'm in front of a patient and they say that they're vomiting blood, they have hematemesis, and if we've been able to pull from the problem list that they have primary biliary cirrhosis, then being able to nudge the clinician when they hit pause or stop, not interrupt them, but nudge them when they hit pause or stop and say, hey, were you talking about portal hypertension? Because we sort of heard it in the negative space. We heard it in the tips that you recommended. We heard it in the way you addressed or the meet criteria we sort of pulled out. Because a lot of clinicians don't want to verbalize the specificity of the diagnosis the way the rev cycle expert would want to see it. But being able to sort of help the clinician be as natural, as organic as they need to be and speak in the right words at the right level to the patient in front of them, but also have their back in creating that clinical document for the other person that they need to serve. I think like what's baked into even the name of our company is that as clinicians, these documents have so many stakeholders. They're serving other clinicians who need to understand what I was thinking when I prescribed that tips or that procedure. They also need to serve all things related to HCCs and value-based care. There's the E&M, challenge with CPTs and level of service, and then of course there's the inpatient story with DRGs, and then finally there's the patient. And so it's an absolutely impossible task for one artifact or one person, one human to create this master artifact that checks off all of these boxes, but that's where this technology comes in that we can sort of do that style transfer and create not just the documentation, but also the structured data artifacts that can sort of help the clinician focus on the person in front of them.
Well, thank you. I feel like we just got an amazing glimpse into the future of healthcare, not just IT, but the future of healthcare, how it may work. So let's give another big hand to our panel and thank them for being here today.